So, Dr. Scholz, today we're going to be talking about hormone therapy and radiation. So, the first question we have is from a patient who is concerned that after radiation, the chances of, secondary cancers such as, bowel or bladder cancer can go up from, they heard it can go up from 1% to 50% over 5 years. And they're wondering, is this true?
That's certainly not true. But the question is a good question because we know radiation could, in theory, cause secondary cancers. The technology has gotten so much better now. The radiation that we target, say at the prostate, for example, is very focused, and the doses are so high, there's no cells left over that could mutate into another type of cancer. But at the edge of the radiation, especially with older radiation, the transition from where the spot is being radiated to the areas around there that aren't being radiated was more of a gradation. And at some point, there was high radiation doses that weren't powerful enough to eradicate the cells altogether. And in theory, some of those could convert and mutate into another type of cancer. And for where we're treating the prostate, you mentioned the bladder and the bowel, which are very close. With much more accurate radiation, with technologies like SpaceOAR, the chances for secondary tumors is very, very rare. We've been following patients now more than 20 years. I have seen one case of what I think was a secondary rectal tumor from a poorly performed type of radiation many, many years ago. But it's extremely uncommon. And the better technology we have today, I think, almost eliminates this concern. It'll never be completely gone, but it's way, way less than 1% risk. And that idea that people are inevitably destined to getting secondary tumors is really ludicrous.
So you mentioned SpaceOAR. Can you explain, is SpaceOAR something that every radiation oncologist uses? Is this something that's widespread, or is it something a patient would have to ask for?
I'm not quite sure. I tend to refer to select centers where SpaceOAR is used routinely, but whether it has been adopted widely across the country, I'm not sure. It's something that people should ask for because it pushes the rectal wall out of the radiation field and eliminates the risk for serious proctitis, inflammation of the rectal wall, which used to be a rare but very, very devastating side effect. So it's something probably that should come up in conversation when patients are talking about radiation with their radiation therapists.
And I've heard that SpaceOAR, it takes about 30 minutes to put in prior to the treatment, correct?
Yeah, it doesn't have to be put in at exactly the time of the treatment. It can be done in a different day, but it's installed in a brief procedure.
Okay,
Yeah.
and do they use a painkiller at all or anesthetic or anything to help with that?
They'll put Novocaine on the skin, where it's injected through the skin of the perineum into the right behind the prostate. It's a little uncomfortable, but prevents the possibility of long-term damage, which makes it more than worthwhile.
And how long does it take to dissolve?
So it stays in place for about 90 days, and then it converts into water and disappears completely.
So we have a patient who just finished radiation and hormone therapy, and now they're wondering if they can take a testosterone booster. Taking testosterone after hormone therapy, is that safe?
Well, if you think about it, men who are stopping hormone therapy, which blocks out their testosterone, are taking testosterone, although it's coming from their own testicles. It's not coming from a cream or a shot. And this question comes up quite a bit because some, especially in elderly men, if they've been taking Lupron for a long time, the recovery of the testicles can be very delayed, or sometimes you can be left with permanent low testosterone for the rest of your life. So taking testosterone is a natural question in these people because we know from studies that after a certain period of time, probably 18 months or so, you're not getting any additional anti-cancer efficacy. In men that have been left in this sort of destitute state with no testosterone, why not give them some testosterone to restore the normal milieu in their body? And there's really no arguments against it because it's exactly the same testosterone that comes from the testicles. There's no difference. The use of testosterone as, say, an injection or a cream will sometimes cause excess production of red cells. So it's a completely separate issue from what people normally think about. They're worried about the cancer coming back. And now with PSMA PET scans, I mean, maybe it's good to find these spots early and address them. But the real concern is not the cancer coming back, because we can monitor for that and act accordingly if it does come back. And the testosterone doesn't promote, more cancer coming back. It may reveal it if it's there, but it doesn't cause the cancer to come back. The real issue is that the red cells, if they are indeed produced in excess, can cause predispose people to heart attacks and strokes. And this is well reported in the testosterone industry. It doesn't have anything to do with prostate cancer. So I always caution people that if they are taking testosterone, that they need to monitor their CBC and their hematocrit levels. And if their red cells become, if they do start to produce excessively, that they get either donate blood or reduce the dose of testosterone. But most importantly, that they monitor for high red blood cell levels.
How often do they need to monitor for?
When you're first starting off, you want to check it probably every 6 weeks a couple times, and then if everything's stable, every 3 months a couple times, and then after that, probably at least twice a year.
Do they need to go to their family physician for this, or can they just go to a lab and check their levels?
Well, a doctor has to order these blood tests, so whether it's a family physician or their oncologist, whoever's prescribing the testosterone will usually be savvy about this sort of issue. But it's good for the patients to be aware of it as well.
So we have a question from a person in Spain, and they have Gleason prostate cancer. They have a metastasis on their lumbar spine and on their pelvic region. And their doctors have prescribed Casodex and Lupron, and he's concerned because nobody's prescribing radiation to take care of the spots. Is this typical? I know he's in a different country. Maybe it's treated differently in the U.S. What would you do?
Well, this comes up to the rich and evolving area of what we call oligometastatic prostate cancer. Oligo in Greek means few. And historically, the idea of zapping spots on the bones with radiation was considered inappropriate. And there was no conviction in the medical world that that would be helpful. The thought was that there's cancer everywhere. That's just the tip of the iceberg. And you're, lopping off the tops of icebergs, but the iceberg's not going away. There's going to be more cancer coming back later. That thinking has changed a lot for several reasons. One is that the scans have gotten better. In the old days, the scans were very poor, and so you were just seeing the tip of the iceberg. But modern scans are seeing perhaps most or all of the cancer. And so since it's easy to radiate these spots and sterilize them, why not? And studies are coming out now to confirm that the people that do radiate these spots do better long-term than the people that don't do it. So there isn't much downside. It's not going to lead to a cure in everybody, but in a few people it will lead to a cure. And the radiation, since it doesn't have many side effects, you definitely would want to do it. We don't know what kind of quality scans they're getting over there in Spain, but it's certainly reasonable to have a discussion with the doctor about the possibility of radiating these metastatic spots.
So this is more of a statement that a patient put as a comment on our YouTube channel, but I thought it was an interesting concept. So there was a patient who had proton therapy, and 4 months out, they're having really good urinary flow. They're taking Flomax once a day, and they're not having many urinary issues, and they think it's because they chose proton therapy. So is that true, that it would be proton therapy versus any other type of radiation?
No, probably not true. The way I conceive of proton therapy is like a methodology that's very similar to other state-of-the-art forms of radiation. No worse or no better. Can men go through radiation without any undue urinary problems? Yes, all the time. That's not at all surprising. So I don't think that it was specifically because he had proton therapy, and it may not be because he specifically had radiation. Some men will notice improvement in urinary function after radiation because their prostate will shrink a little bit. Other men will have no change. Other men will have some increased problems due to inflammation of the urethra. So I think that the fears that radiation was going to transpose into long-term urinary problems have been quelled a lot with improved techniques. Also, I'm seeing with seed implant radiation where they're able to keep the radiation off the urethra, these men seem to do better than what we historically expected with radiation treatments. But no, I don't think it's specifically the proton therapy itself, even though that is a good type of radiation.
So we have a patient who's 62 years old, they're newly diagnosed, and they have a PSA of about 13, and their Gleason score is 3+4, and they've been given 3 options for treatment. Now, the great thing about this patient is it sounds like they've gotten multiple opinions, so their urologist told them surgery, and then they saw a couple radiation oncologists, and they suggested either external beam radiation or brachytherapy. So given the situation, what would you have them choose?
Well, we need a lot more information. There are many types of 3+4. With a PSA of 13, it sounds like, well, you're inevitably forced to have treatment, but some men with really large prostates are going to have a PSA of 13 with no cancer at all. So we don't know how big his prostate is. We don't know if it's on one side or both sides. So in men that have unilateral disease, focal therapy is very attractive because the incidence of erectile dysfunction is much less. We don't know if this man is highly motivated to preserve sexual function. Most 62-year-olds will be very motivated to preserve sexual function. So some form of focal therapy, which can be done with radiation or brachytherapy or other methodologies like HIFU or laser or electroporation, cryotherapy, all those things would be a consideration. So I do tend to shy away from surgery in general because surgery is accompanied by problems with urinary incontinence, which doesn't occur. If it does, it's very, very rare with radiation. And then, of course, all men after surgery become impotent, and then a percentage of them recover, which is rather daunting prospect. So surgery is not an attractive option for me in this modern era. But the details of this gentleman's case are spotty, and especially with 3+4, you're looking at some men might even be able to do active surveillance, do focal therapy, and if it just comes down to the 3 options that we've been offered, brachytherapy would be my preferred approach as long as the prostate's not too large, and same thing for radiation. If the prostate's very, very big, then radiation become more difficult, and then focal therapy even becomes a more attractive option for those people.
Thank you so much for watching this video on radiation and hormone therapy. We know that you are facing many decisions regarding to what type of treatment you're choosing, and we are here to help you research. Your research is going to be the biggest factor in making the right decision for you, and we thank you for allowing us to be here. If you have any questions or comments, you can go ahead and leave them in the comment section below this video. We hope you have a great week. Thank you for trusting us, and much love.